Good morning. It's good to see you as always. Thank you so much for joining us on My Doctor. We always appreciate your company. My name is Winnie Lubem, and of course, remember this is a show that gives you all the information you need to have concerning your health, and of course, help you make better health choices. Now, today on My Doctor, we'll be talking about fibroids, and I know this is not a new term as far as all women are concerned, because we've heard, or I'm sure you've had one or two or even three women talk about fibroids. But do we really understand what fibroids are all about? How do you get it? Do all women get fibroids, or do they have fibroids? Well, with that, we have that and much more in our show today. So be sure to stick around till the end of the show and ask any question that you have in regards to the topic that is on fibroids, and we'll try as much as possible and answer them before we end the show. But now, before we get into the discussion, take a look at this video on fibroids. All right, a lot of information right over there on fibroids, but don't worry, just in case you tune in and the video was halfway or almost over, then don't worry, because that is what we'll be focusing on, and that is on fibroids. And like we always say, if you have any question in regards to the topic of discussion, then feel free to ask the number to call us 0791 478990, and we'll try and answer all your questions before we end the show. But of course, to help us understand what fibroids are, who gets it, how do you get it, how does it occur, how do you treat it, I mean, all those questions in regards to fibroids, I am joined by Dr. Maureen Awiti. Good morning.
Hi Winnie, how are you?
Good, how are you?
Yes.
It's good to see you. Now, fibroids, okay? And like I said, we hear so many women talk about fibroids every single day, here and there. You know, me, I had fibroids, and probably it was difficult for me to get pregnant, or when I got pregnant, they disappeared. You know, like sometimes it's difficult to understand how that exactly happens. So let's go back all the way to the basics. What are fibroids?
Okay, so I wish again, I think the video did most of the work for me. So I'll just recap what the video said.
They said, okay.
Anyway, fibroids are growths, okay, and they arise from the muscle. The uterus is actually a muscle, so the uterine wall is muscle tissue. Okay. So it arises from there, and it's just some fibrous tissue, and it can be very small or they can be very big. I just wanted to clarify regarding the reason for hysterectomy, that's removing the uterus. It's not necessarily because of the size of the fibroid. Having had said that, it was, I think, some Western country, they don't see as big fibroids as we do here. So I think here the doctors, we've seen really huge and many fibroids, so we can remove really big and very many fibroids, and it would actually depend on the woman's desire for future fertility. So if she still has desire for future fertility and has a big fibroid, we'd still remove the fibroid.
All right. And talking about fibroids, I've seen women who, let's say, look pregnant, but then again, it's very confusing, because when you talk to them, they'll tell you, I am not pregnant, this is just fibroids, and you wonder, like, okay, how big can they get? But now, before we even get to that, someone might ask, okay, so how do they come about, and you know, why do they grow?
Okay, so as I said, there are many things we don't understand. Yes. So again, fibroids, unfortunately, we have not determined the exact cause. However, the video was very clear that we do know it only occurs in women in reproductive age. And this is seen whereby somebody who has not started menstruation, you're never going to get somebody like that. In fact, we discover that person, if she's going to undergo a lot of studies if she has fibroids before she starts getting her periods. And then again, once your periods end, when you go into menopause, again, fibroids will shrink, and some people even altogether disappear. So it's related to your estrogen levels, and the estrogen that is most common during a reproductive age is the estradiol level. So that's all we know. Another Nobel Prize there. Yes.
All right, for someone who gets to understand why. Now, and of course, talking about the levels of estrogen, and we also saw that, what are some of the, would say, triggers to, you know, the different levels of estrogen in different women?
So, again, your whole life, your reproductive, like even you getting to starting your periods, it's a hormonal event. These are things controlled by genes, you understand? And if they're working properly, you develop or use certain types of hormones during certain types of your period. So once you're in reproductive age, the most you get, it's estrogen, that's a very dominant hormone, and that's what we know. And because of that, that's why we postulate. We don't know. We are postulating that this is related to why there are fibroids. Now, I think they were, again, very, very clear that somehow pregnancy is protective. So you find that women who have many children don't tend to have fibroids, whereas women who have no or very widely spaced few children tend to have get fibroids.
All right.
Another thing that was not there was, again, race in terms of causes. So we have things that give a high association. So you find it's more common in women who have not given birth, and again, it's more common in Black or African race. Yeah. So yes, fibroids are found in all races, but you find actually there's a high incidence among Blacks, so that or people of African descent. Yes.
Again, do we know why, or there's no specific reason
why?
I'm
very clear. That will be another. The person who discovers that one, another Nobel Prize.
On why it's more on the Black women and African women than it. All right. And then there's another question someone might ask. Okay, so why is it that other women get it and other? I mean, some women get it and others don't. Is there
so we've said
or don't know? No,
again,
nobody knows.
It would again look at. To be again look at the history. And if you want to protect yourself against fibroids, get babies.
Wait, and then on babies, like, is there a specific age where, let's say, get babies before, let's say, this?
I wouldn't say. I wouldn't say.
All right.
But it's just that. Just at looking at women, if you'd ask me the ideal weight to start having children, I'd say between 24 and 28. Yeah, but that's my opinion.
It's
not
because
scientific.
When you say get
not scientific.
When you say get babies, I'll be like, I will have a baby every single year so that I do not end up getting fibroids. But as long as you can take care of them, there's no problem with that. Now let's talk about the different types of fibroids, because from the video, there were different terminologies like myomas and this and that, and we're like, so what are those? Just simplify them for us.
So again, fibroids is the layman's term for the growth. The scientific term for a fibroid is actually a leiomyoma. Myoma is just short for leiomyoma. So all those terms mean exactly the same thing. So leiomyoma, myoma, fibroid equals. So they're one and the same thing. So don't stress. Don't stress about that. So they're interchangeable and mean exactly the same thing. Now you were talking about classification. We classify fibroids based on their location. Again, just understanding that, as I said, the uterus is a muscular structure. So if you have, say, this is the inner lining and that's the outer lining of the fibroid. The inner lining, we call it the mucosa. So any fibroid that's indenting on the inner lining would call that a submucosal fibroid. Anyone that's inside the tissue, it's neither going to the mucosa or to the outside cover, that's an intramural. Mural means wall, so that is a fibroid inside the wall, of the uterus. And then we have the ones on the outer covering, we call the outer covering serosa, so such a fibroid would be just a subserosal fibroid.
All right. And are there specific reasons why maybe they grow maybe in the inner lining or the outer lining?
No, it's just the location it started growing. So and as I said, we don't know the cause. So why say growing in that particular place? I guess we also don't know.
All right. Now, in terms of fibroids, how do all of them get detected and diagnosed at the same time, or it's different? In terms of the detection and the diagnosis.
Again, the beauty, and I think she said that a lot of people actually have fibroids and probably don't even know they have fibroids, in that a lot of people don't have symptoms. So what am I talking about? It means that we only deal with people who have symptoms because of their fibroids. Fibroids are benign. Benign means that they don't turn cancerous. So they can turn cancerous, but in very rare occasions. It's in about if I have 2,000 women who have fibroids, maybe one may get cancerous change from the fibroid. Unfortunately for that person, it's 100%, and it's very traumatizing for everybody. And even I really put that into perspective. I think maybe because I'm not an oncologist, personally, I've only ever seen one patient who had a sarcoma, that is the cancer, arising because of a fibroid. However, I'm sure there are many more patients out there. But so generally, if we diagnose fibroids in you, it's something that you should relax, that in as much as it is a growth, but it's generally not a cancerous growth. You understand? So therefore, we really don't need to interfere with you much unless it's causing you problems. For us, probably because our fibroids grow very big, our most common symptom would be menstrual abnormalities. So you find a lot of people get very, very heavy periods. So what would happen is that you'd notice that your period is gradually increasing in terms of the duration, that maybe you used to have periods for 3 days, all of a sudden they are 4 days, 5 days, a week, 9 days. Yeah, like that. But it will be a cyclical period. Then maybe you use 3-4 pads in a day. All of a sudden you need to use 10, a whole packet in one day to contain the bleeding. So personally, from my experience, my most common symptom that brings women to the clinic would actually be increased flow during their menstrual period. Other symptoms, I think the video aptly put it, whereby you can be constipated or even obstipated. That means you can't even pass. You can't even pass stool. You may have increased frequency of urine if it's pressing on the bladder, or again the opposite, whereby you're not able to urinate, depending on the location of the fibroid, and other discomfort. Pain usually will be because of two things. It's either the fibroid is pressing on some structure that has very good nerve supply, or actually on a nerve, or because the fibroid is degenerating. I've tried to find a word that means degeneration in layman's, but it's basically it's breaking down, it's undergoing some changes, and that's the reason you're having pain. So that's that's the second most common reason people will come to the clinic, because they're having pain. The pain can be during the periods, or it can be throughout the cycle. So when somebody's having symptoms, that's when we deal with it. So I've talked about increased flow. So if they have increased flow, they can get anemia. We have people even need to get transfused because of the level of blood loss. The anemia is that severe. They're getting dizziness, headaches, fainting spells. It can be very dramatic, and all because of a period. And this period is made worse because of the fibroid. So for me, that's the most common reason people come to get assistance because of fibroid.
Because when you talk about, the increased levels of periods, and then again talk about, other cases where people faint. I remember when in high school, I think we used to have, such cases of people have like really, really painful periods, and then most of them end up, fainting and all that, and nobody understands why, and they're given painkillers, and then that's it. But I think from what you said, it's good to just go get checked, and they rule out. All right, is there screening for fibroids?
At least fibroids, because there's a growth, and there are very specific signs you see on ultrasound. So if somebody comes, we examine them. We'll take the history, what is the chief complaint, and then we'll do an exam. So in a lot of people, I don't know, our fibroids are huge, so you even find that you do just abdominal exam, and you're able to determine that the uterus is actually enlarged, and she's actually on her period, so she's not pregnant. You understand? Some people, they may be smaller, so if you do an ultrasound, we're able to actually see the fibroids on ultrasound. A lot of people actually discover they have fibroids when they're pregnant, because I said they don't have any symptoms per se, and then you're doing your routine scan when you're pregnant, and voila, there she is, a fibroid, or even many fibroids. So if the fibroid is not causing any symptoms,
okay,
we generally just advise the patient that we really don't need to do anything much for the patient.
Okay.
If, however, she's having symptoms because of the fibroids, at that point is when we decide, do we now need treatment?
Okay.
Yeah.
All right. So some present symptoms, some do not.
Yes.
Okay. But generally, it's usually advised that women just go for checkup maybe once a year or twice a year, or how frequent are we supposed to go for this?
Okay. So again, looking at that, when you go to your gynae, there are various things that we do for you.
All right.
So it will be ranged from your breast exam, which is advised every year. So at least we have agreed the frequencies every year.
Every year.
To your pap smear, which used to be every year. We're currently advising at least once in 3 years.
Once in 3 years,
yeah.
okay.
So, and just take care of other needs. Are you having a baby? Do you want contraception? What is it? So, and if you're say on contraception, it needs to be monitored and how you're doing and what's happening.
Okay.
So the minimum I'd say for a review would be at least annually. Go and see your gynecologist.
Oh, okay.
Yes.
All right. And could there be, let's say, a link towards use of contraception and fibroids? Because I've had some people say, I'm scared of using contraception because I'll get fibroids.
Okay. I'm very clear
that
not having a baby
could cause fibroids. Okay.
So if from point of view, you've used the contraception, you're not getting babies, it's not because of the contraception, but because you're not getting children. Yes.
Okay. It's plain blank and period. All right. Okay. Now, when you talk about the sizes, you said, unfortunately for us, you know, we get like really, really big fibroids. So at what rate would you say, once detected, at what rate do they grow? And does it get to a point where it's dangerous if it's not removed after it gets to, let's say, a particular size?
Okay. As I've said, fibroids, they're not cancerous. You're comfortable with a fibroid the size of a pregnancy. It's not causing pain, it's not causing pressure, it's not causing heavy periods, it's not causing whatever. Hello, be my guest. But what's the probability you're having this fibroid the size of a full-term not causing some symptoms? So again, I'm very, very clear. As long as you're not having symptoms that are disturbing you, and even cosmetic effect, like you said, somebody looks like she's pregnant. It's disturbing her that everybody's asking her, are you pregnant all the time?
Yeah.
It's a symptom, you understand? So as long as she has symptoms that are disturbing her, you understand? At that point, it warrants doing something to remove or reduce the size of the fibroids.
All right. Yes. And how big can they get?
As I said, a term pregnancy.
All right. No, but when you remove it, like, how, could you sort of like measure it and say in terms of kilos or whatnot? Or
I think we have I personally have not removed a 1 kilo fibroid, but we've had, like, I remember there was a case, somebody had full term multiple fibroids. So if you are in total more than 3 kilos.
Wow.
Yes, even 5.
Okay.
Yeah. All the fibroids put together.
Okay.
Yes. So
all right.
it's quite heavy.
Yeah, I can imagine. I think it's what you said about, you know, sometimes a woman looks pregnant and they're not, and then people keep questioning, when are you due? When are you due? When are you due? It can be traumatizing, I would say, and someone might go into, you know, self-esteem and
again, understanding that health is not just the lack of physical ailment, it's also psychological.
Yes. Okay. All right. And are there some of the risk factors, you know, for fibroids?
Okay. So again, as we've said, that the uterus, when God put it in women, its function was to have children.
Okay.
You understand? So please use your uterus appropriately.
Okay. But what of those who do not want to have children? Because there's some people who,
again, like understanding that it's not everybody who doesn't have children who's going to get fibroids.
Okay.
So there is some predisposition. So again, there must be some genetic link, because again, you'll find it runs in families and stuff like that. But as I've said, we have not proven beyond doubt that this is actually the case. So mark you me, it's not for everybody, but it is protective to be pregnant.
Okay.
Yes.
All right. And is it possible, because I've had also people say that they're pregnant and they had fibroids, and of course it never had an effect on the baby. The baby was born, you know, healthy, and then the fibroids disappear. So just help us understand how that happens.
Okay. About the fibroids disappearing after she was pregnant, I find it what I would say is they shrunk.
Oh, okay.
They shrunk.
They didn't disappear completely.
Unless they were removed.
All right.
At delivery. And unfortunately, we do not advocate for removal of fibroids during delivery, pregnancy. Even if it's via cesarean section, because again, because of pregnancy, you're very, very well vascularized. It can bleed. This can lead to death. So we don't advocate for removal of fibroids during cesarean section. So she didn't know she had the fibroids. She got pregnant. You understand?
Yes.
Now, during the first 2 trimesters, that's the first and second trimesters, you find fibroids increase in size exponentially, very fast and very rapidly. After the second trimester, they become stable throughout. So whatever size they reach in the second trimester, they're not going to grow much more in the third trimester of pregnancy. So that is probably why they were recognized during her scans that she actually has fibroids. But then after pregnancy, see, the uterus shrinks back and the fibroids also shrink back to the original size. So not that they disappeared, they just shrunk back. And I think that fibroid can be microscopic, or there are those we can see with the naked eye. So maybe probably these were people who had very, very tiny fibroids that were not easily to see on the scan. But most probably such a patient, if we're able to diagnose the fibroids during the pregnancy, if she was to do a scan, she'd actually see that she does have fibroids. They just maybe not so big.
Maybe tiny. Okay. All right. And are there cases where, let's say, as the baby grows, the fibroid grows?
Yes, it's what I said. In the first trimester, in the second trimester, fibroids grow, and they grow very fast during that period. Yes.
But then, because like you said, in the third trimester, it sort of stops growing.
Whatever size, like just say it was a 10 centimeter in the second, it's going to remain like that until the end of pregnancy. Yes.
But now the question is could we have cases where even the third trimester, it still continues to grow?
Okay. From what we know, that's what happens. But as I said, I never limit myself to what can happen in each.
All right.
Yes.
Okay. Now, seemingly complex and all that, but of course, we're glad that you're here to help us understand more about fibroids and all that. And you also talked about instances where someone could have fibroids and do not present any form of symptom. But of course, we still have, things to do with treatment and some of the complications that might arise, during removal of fibroids. But of course, that we'll discuss after the short break. So if you have any question in regards to the topic, then feel free to call in live and we'll try as much as possible and answer them before we end the show. But for now, we're taking a very short break. We'll be right back with more. Stay with us. All right, welcome back. Glad you're still with us. This is My Doctor. My name is Winnie Lubembe, and of course today our focus is on fibroids. And like I said, when we start the show, we hear a lot of women talking about fibroids here and there. Sometimes it can be difficult to understand what exactly are fibroids, but of course from what Dr. Maureen has told us, well, we don't really know what causes fibroids, and we don't really know how, why is it that some women get and some women do not, get fibroids. But we also talked about diagnosis of fibroids. Some you can see, some you cannot see until you go, and get checked. But now, let's talk about some of the things that women talk about, and that is, does it endanger the life of, let's say, a fetus growing in the mother's womb?
Okay. So again, we'll say again, it'll depend on the position of the fibroids. So if I remember, I said like there were those that grow in the inner lining of the uterus. Such fibroids would be associated with a higher risk of miscarriage. Whereas the ones which are the outer lining, you understand, unless they're very, very, very big and causing a really mass effect, you find such fibroids, such patients would be able to go till term. But fibroids in general are associated with a higher risk of miscarriage during pregnancy. But please note it's a higher risk.
Higher risk. Okay.
Yeah. It's not an absolute risk. Yes.
Okay. All right. And are there some of the things that probably you can do to prevent some of these risks that you talked about, especially during pregnancy?
Okay. Now, as I've said, if it's the first time you've diagnosed, it really presents what we call a management dilemma.
Okay.
I think that would be the word. Because you look at surgery in itself, maybe like you're worried about a miscarriage. You understand? So meaning you want to have a baby.
Yes.
You understand? And you have fibroids. And you go ahead, have surgery, remove the fibroids. And then you can develop those adhesions. Now, adhesions are just structures in the pelvis that make everything stick together. And that would again lower your chances of getting a baby. So it really depends on what symptoms do you have before the pregnancy. And if you're relatively asymptomatic, I actually would advise most of my clients probably to just try having the baby. We see what happens. You understand? It's very difficult to tell somebody to try having a miscarriage. But who knows, she may not miscarry. If she doesn't miscarry, I think it would have been a good decision. If, say, she happens to miscarry and we know there are fibroids, it may now warrant us taking that risk of removing the fibroids with, again, another potential risk of her not being able to conceive in the future. But, as I've said, there are so many options for fertility treatment. So that is an option. It's just definitely, unfortunately, it'll be an extra huge cost.
Okay. And in terms of the treatment for fibroids, let's just talk about that. In terms of is surgery the only?
No, there are so many. In fact, like fibroids is one of those things if you have, because it's so common around the world, regardless that it's more common among us as Africans, but it's something across the world. It's something you see everywhere. So treatment again would be targeted to what is the symptom. You understand? So again, we find you have low blood levels, we'll give you something to boost your blood. You're having pain, we'll give you something for pain. Now, the main thing that people ask would be, can we, is there medicine that can remove? And please know the word remove the fibroid. There's no medicine that can remove the fibroid. The best medicine can do is maybe shrink the fibroid. But it's really understanding that whatever medication you're taking to shrink the fibroid, it will work. It will shrink, and it'll be a smaller size for a relative period of time. And after time, the fibroid is going to continue to grow, to grow back. So there are many modalities that are based on that principle. So, and again, I think the pill is used for everything in gynecology. So that will help reduce the amount of flow, because I said the most common symptom is the heavy menstrual flow. Heavy menstrual flow. You can use some what we call painkillers. They will reduce the pain and actually do help in reducing the amount of flow as well. You again, progesterone, for us everything I think we treat with pills and progesterone. Yeah, I'll think about it if there's something we don't, maybe an infection, we don't treat with pills and progesterone. Yeah, so again, progesterone supplement tend to reduce the amount of flow during your periods. We have some substances that reduce the amount of flow. They increase, like, reduce amount of what we call fibrinolytics. So they we can also use that to reduce the amount of flow. Then we have the injection I was talking about, such as Lupride or Goserelin, and those would cause, again, a fake menopause. When you're having fake menopause, it means you have no or very scanty periods. And those will actually cause the fibroids to shrink. And again, adding to the fact that we think that is because of estrogen, because those do lower the levels of estrogen during that period. So those would actually cause the fibroids to shrink. And we normally use that prior to surgery so that we have a smaller fibroid to remove, you understand? And it also gives us time to boost your blood levels. You're not having periods, your blood levels are going to go back up. So that's the advantage. In terms of using it long term, that maybe we shrink the period so you can conceive, it's really understanding. It's kind of like, for me, it defeats the purpose, because you find you don't know how long we're going to take to conceive.
Yeah.
So we now move, I think before surgical, we have what we call the uterine artery embolization. So in uterine artery embolization, we know that the blood supply to the fibroid is exclusively from the uterine arteries, whereas the uterus gets supply from both the uterine and ovarian arteries. So we are going to block the uterine arteries, and in that way, we are blocking the blood supply, and it causes some of the fibroids to shrink. It causes the fibroids to shrink, and even some of them can actually be shed off. Unfortunately, for people who want to conceive, we don't have enough data to say whether it would be safe for future fertility and any effect on the offspring. So I cannot say it is safe or it is not safe. So we would not advise for somebody who intends to have children in the future to have that procedure. Okay. Then the last is obviously surgery. Now surgery, there are two types. Actually, I'd say maybe there are 4 types, but I'll just say there are 2 types. We can, in general, we can either remove the fibroids or remove the uterus. Okay? So obviously, if you want to have children, removing the uterus would not be an option. And we call that a hysterectomy. Okay? Both removing the fibroids, just the fibroids, or removing the uterus can either be done via open surgery, do we do a cesarean section, or by laparoscopic surgery. And in terms of the ideal candidates for laparoscopic surgery would depend on the size of the uterus and the competence of the surgeon.
All right. So someone might be like, suppose I do not have any form of, let's say, pain or anything, but I can see, you know, I have fibroids and I want them removed completely. Is that okay? Can I go through, you know, surgery to just remove it? Because I mean, I don't like it. I don't want to have it, regardless of whether I have pain or not.
Again, really understanding that your fibroids, removing it would either be via, I think in the film, the vagina. You understand? Again, cause possibility of causing adhesions within the uterine cavity itself, or via the abdomen. And those are very risky surgeries. So for me, I still maintain, if you're not having symptoms, you understand, there's really no need to undergo surgery. You understand? So there must have been something that led to us discovering that you have the fibroids. So if it's just an incidental finding, maybe you had some minor discomfort and it was a UTI, a scan was done, we saw something. Such a patient, I'd really just advise them. You don't really have major symptoms because of the fibroid. I'd highly discourage them from undergoing surgery.
All right.
They have symptoms, I'm very, very clear. We'll advise them on what their treatment options are. We'll discuss with them and come up with what they think is a comfortable plan for them. Purely on the patient to decide what's best for them. It's something. It's an informed choice. It's an informed choice because, as you said, okay, for that patient who wants surgery, purely because she knows she has a fibroid, has no symptom, really just needs to be talked to understand, again, what are the pitfalls in surgery, what are the possible complications because of surgery, so that they understand what they're putting themselves through. Because even somebody who has symptoms, I'm still going to go through with them what are possible complications, because this surgery is a very serious thing. It's not something that we should take lightly.
Yes. And how long does the surgery take?
Again, would depend on size, number, location of the fibroid. So there's somebody you go in, pedunculated, just chopped off the stalk. You're out in a few minutes. And there are people, you're 3 hours down the line, you're still fishing more and more fibroids.
So the size and number. And in terms of the number,
and location.
How many can they get to?
I'm telling you, I think I had a group of my colleagues, because I also work at Kenyatta National Hospital. We've recently removed about 50, and there's somebody who said that they removed about 70 fibroids.
Wow.
Yes.
So again, I know we talked about some of these things, the causes we don't know, but the number, do we know why some might have 10, others will just have 1, another one will have 50? Still no.
You have somebody who has one huge fibroid, the whole tummy, and it's 1. And there's somebody who has a tiny uterus, maybe like this size, and has like 20 fibroids in there.
Wow. Okay. Now, you also talked about some of the complications.
But what I find interesting is, for us, most of our fibroids tend to be a number.
Okay.
Yeah. Though we have had instances where we've just moved one large fibroid, yes.
Okay, most of the majority is a number of them.
Yeah.
Okay, now we also talked about some of the complications that might arise during, especially, and this is for the surgery. So what are some of those complications during surgery and even after? Like, can they cause like a long-term, let's say, complication? Because I know for hysterectomy, of course, someone might not be able to have a child. But then again, for this other type, laparoscopy, what are some of the complications during and even like long term?
Okay. Any operation in the abdomen, any operation, infection is going to be a potential problem, and it can be in the blood or just on the wounds or port sites for the laparoscopy. Bleeding, I think, is a major concern for myomectomy. So you find even a hysterectomy, you may find some surgeons are confident enough to go for removing the uterus without blood being available, but very, very few surgeons will not prepare blood when they're going to remove fibroids. It have to be there very clear, it's just one, it's not going deep into the muscle tissue, so very little blood loss is going to occur. Now, again, especially for those who are interested in having babies in the future, it's always a discussion that is had with them that during removal of the fibroids, there's a very high possibility that if they're not able to contain blood loss, they could actually lose their uterus. We'd have to remove the uterus to contain blood loss. Fortunately, with advances in surgery, there are many modalities we use to reduce the amount of bleeding during surgery. So nowadays, a lot of removal of fibroids, we really don't end up removing the uterus. So we thank God. We thank God for that.
All right.
So, but bleeding with transfusion and possibility of removing your uterus. There are also, like, from severe acute blood loss, even infertility. You find that there's a gland that's responsible for production of your hormones in your brain. It's very sensitive to blood loss, and some people may not be able to conceive just because that gland has been, its function has been compromised if you have severe blood loss during surgery. Then injury to any of the near organs, and especially during, like, say, a hysterectomy, the ureter, that's what takes urine from your kidneys to your bladder. That I think urologists, I know that they like or hate us, one of the two, because we are usually responsible for damage to ureters, which they now have to repair. But any pelvic organ can be damaged. So the bladder is in front, especially like people who've had cesarean section previously. You find the bladder kind of sticks to the uterus, you want to remove it, you risk damaging the bladder. Intestines, again, because the fibroids, it can cause an inflammation and they stick together, so you can get even injury to the intestines. So, as I said, surgery has a lot of potential complications, but we are taught to do surgery, to be very gentle with tissue, to be very careful with what we're doing. So fortunately, in as much as we do have surgery, we don't have that every single patient who has undergone surgery has a complication. But any good surgeon is going to tell you very honestly that these are potential complications, and it's really understanding that you have a complication. It's not because your surgeon is bad at what they do. It's just a complication occurred. You should have been aware, and we also agree that should any complication occur during or even after surgery, that as soon as it's diagnosed, you are open and willing for that complication to be managed so that it doesn't blow out of proportion. The worst complication being known as death.
Oh, yes. Okay. All right. So, but like you said, it's important to just talk to the patient, take them through some of the risks and complications, so that by the time they make a decision, they know
what they're putting themselves through.
All right.
And what I've really found that if you really explain to the patients well, they tend not to get complications. I don't know why.
Let me take
and the ones you don't go through,
They have complications. Okay, yes. So how long does it take to heal from the surgeries?
Again, healing is relative. So the beauty with, if you're able to do the operation laparoscopically, you find that healing occurs much faster because they have a much smaller raw area that needs to get. But it's really understanding whether it's a hysterectomy is open or laparoscopic, it's still a major surgery with all the potential complications of a major surgery. Okay? But definitely with laparoscopy, or even if we're actually able to remove the uterus, if it's not very big, also via the vagina. We call that a vaginal hysterectomy. You find that if you do a vaginal hysterectomy or a laparoscopic hysterectomy, that the healing is much, much faster than an open surgery. But as I said, it depends on the size of the uterus and the competence of the surgeon.
Of the surgeon.
Yes.
Okay.
But healing generally, you find that just say the laparoscopic and vaginal, people are even able to do those as day cases, as in you go in, have your surgery in the morning, and you're home in the evening. So I have some of my colleagues, I think they know themselves if they are watching.
Okay.
Yeah.
All right.
Yes.
Do that in the morning.
Yes. And they have very good, very good results. Okay. Most people will have at least an overnight stay in the hospital. But for open surgery, you find usually it will require at least 2 to 3 bed nights at a minimum, if no complication has occurred. So that is how soon they can be able to go home. Okay. Then once they're home, you find that we normally will give most patients post-operatively some time off, and can range from a week to 2 weeks depending on how fast the person is. So you'll find with laparoscopy, because they should be back faster to the activities, maybe a week would be sufficient, but generally most people are given 2 weeks post-surgery, and they're able to go back to at least some activity. So we just want them not to do like lift heavy objects and do very strenuous physical activity, but work that just involves computer, using your brain and stuff. I mean, even from your hospital bed, you can do it.
Okay. All right. But now, let's talk about, you talked also about some of these complications. Could some of them be picked immediately after surgery, or some of them takes some time before they're picked?
As I've said, during surgery, as a surgeon, their techniques were taught to kind of like try to pick up, but there are those cases that will escape you, and you will not notice during surgery. You will notice them post-operatively. So, but some injuries are very easy to pick up if they occur during the surgery. Some you may not pick up until it's too late. So it's just terrible. So, but it's just one of those things whereby even I'm looking at, like, if I look at what's happening in India right now, that patients are really not understanding that, look, everybody puts their best foot forward. For us as clinicians, we don't do operations to get complications. And we're talking about legit clinicians. Okay? We don't do, because medicine is one of those things whereby our name is very important. Now, if I have that every patient I'm operating is complicating, you who has had a complication are not going to refer me another patient. You must understand that. So there's nobody who does it to do get a complication. So it's really also that people should understand that we do put our best foot forward, but sometimes, unfortunately, things don't really work out as we'd have planned. Everybody wants our patients to get better.
All right. And then another question would be, are there, let's say, home remedies either for treatment of fibroids, and what role does diet play as far as, let's say, preventing fibroids from occurring?
Again, home remedies and all those things will be homeopathic. I'm not a homeopathic person, so I would not be in an exact position to like really advise for those things. For me personally, I would always advise that you generally should have just a balanced diet, and that would help. In terms of stuff that would actually help prevent, for me, I just postulate, they're just things people say. Maybe you are the person who was not going to get fibroids, so you took it, you didn't get, but the person who gets fibroids, they'll take those things and still get the fibroids. So for me, it doesn't make a lot of sense. It's hormonal. So unless it would be something that's knocking off your hormones, which would not necessarily be a good thing. You understand? So basically, it's just have a nice, well-balanced diet with all the food groups, eating a lot of vegetables, fruits, drink a lot of water. You still need proteins and starch. So just a balanced diet.
Okay.
Yes.
All right. And then in terms of let's say the pill, some of these other treatment options, I don't know if I might have missed it, but in terms of let's say someone is on the pill, how long are they supposed to be on the pill, or do they get to a point where they're like, okay, now you can take a break or stop taking the pills for some time and then come back?
As I've said, all the time when we're giving treatment, it depends. What was the symptom? Why are we taking it? There's a reason we chose this particular treatment. So by the time we decided on a pill, it was clear that at that point in time, you were not keen on, say, getting pregnant, a baby. Okay. You understand? Yes. So everything is dynamic. Medicine is not static, that I put you on a pill and now you're on a pill for life. Okay. It would just depend. What are your goals at this present time in moment? You understand? So you're not interested in a baby right now. Maybe you warrant, somebody warrants surgery, you don't want surgery. This could be an option, for you. So it's really looking at it. What is the patient's goals? What do they want? And how can we best assist them to do that?
All right. And then there's a question, but I think we touched on it a little bit, and that is what happens to the fibroids after the menopause. But just in case someone missed it, take us through that.
So as we said, because in menopause, your estrogen levels are going to go drastically down. What we do know is there is relation with the estrogen levels and fibroids. High estrogen levels, you're going to get fibroids. Low estrogen levels, they disappear. So what we do know is that, and what we have observed, that even in women, so you find somebody is, say, 50 years, okay, and still menstruating, and comes complaining of very heavy menstruation. You understand? So that's somebody, you will take them through, you understand, and probably decide, we will give them the injection. Can they undergo the uterine artery embolization to shrink the fibroids as we are awaiting the menopause? We don't necessarily need to remove a uterus. But it's also understanding that all of these things are relative to the cost also, and also what the patient wants. So somebody who's near menopause, you'll find that we'll just encourage them, menopause is around the corner, and probably give them some medical treatment. Or this would be the ideal person to say remove the uterus, because she's not interested in getting children. I mean, very few of us would be interested in getting children at 60. But we expect most of us to be menopausal at 60. But to answer the question directly, because of the low estrogen levels at menopause, the fibroids actually do shrink.
All right. And then another question, but this one asks, can fibroids reoccur after they have been removed?
So the word reoccur would be a misnomer, because that one was removed. You understand? So what we'd say is that you can grow other ones, because as I've said, we removed the fibroid, but we have not removed what caused the fibroid, because as I said, we don't know what caused the fibroid in the first place. So it's not so much that they regrow, no, it's just that you're getting new other ones that are growing, because we still have what was causing them is still present in you.
All right. So chances are, if they come back, then that means it was not removed in the first place.
The fibroid, it's out, so how can it grow again?
No, like it was not. It was not removed in terms of maybe it's
that would be a myth. You understand that people think the doctor did a bad job. He didn't remove the fibroids. See, even we show you photos or even actual the fibroids of what we have removed. So what we have removed is out.
It will not.
But I said, at that point in time, there's some that are microscopic. There's some that are very, very tiny. Even to touch, you're not able to feel. And even when you're doing surgery, you must remember that you have to do surgery in a manner. You're also not mutilating this uterus, because by the time you're removing the fibroids only, this is a person who feels she wants to have children either in the near or distant future. You understand? So you also don't want to mutilate it to the extent that it also now cannot carry a baby because that's what she wants.
Yes.
You understand?
Yes.
So even when you're doing surgery, you must balance. If you're getting some tiny thing, you can't even see it. Why are you destroying the muscle? Understanding that anywhere you cut, it's going to be scar tissue there. Scar tissue does not have the same integrity as the actual muscle.
Itself, yeah.
You understand?
Yes.
So even when doing surgery, there's some principles that you must adhere to. So the obvious big fibroids, some tiny thing that's not going to, you have to dig through to get it.
Please don't. Okay.
Yeah.
All right. So as you finish, what will be a parting shot as far as, fibroids are concerned? Because, like we said, there's so many myths and misconceptions surrounding, the whole topic of fibroids. So what would you say to all the women watching us right now?
Yeah. So for one, if you have fibroids, don't panic.
Okay.
You understand?
Yes.
And only treat the fibroids if you have symptoms that really do warrant something to happen to them.
Okay.
Yes.
All right. Do not just go around wanting to remove it, especially if it doesn't do, let's say, harm or any pain. It doesn't cause any pain to you. All right, Dr. Maureen, thank you so much for coming over today and helping us understand what fibroids are. And of course, thank you so much for tuning in as well. I believe right now we have demystified some of those myths and misconceptions about fibroids that probably you had or you have had. So my name is Winnie Lubembe. God bless. We'll see you some other time on My Doctor, same time, same place, as we discuss another amazing topic. But for now, it's a goodbye from us. God bless. We'll see you some other time.